disorders. We're going to talk about defining autism spectrum disorders and mainly to update. I imagine most people here kind of understand autism and know about autism. First steps after diagnosis, generally recommended interventions, and then a little talk about complementary and alternative medicine. And so we'll discuss that as well. And let me advance. And I guess I have to click here. Okay. So I just want to give a couple of stats just to update on where we are now with the numbers as far as autism. And in terms of the statistics, there has been 175% rise in the prevalence of autism over the past 20 years. So that's a pretty steep rise. The US annual direct costs are $461 billion a year, care for persons with autism. And it is projected that by 2025, the costs for the care of autism will likely exceed the costs for diabetes or ADHD. And so there's a lot going on. And let me advance. So that's my stair step. I've been talking about autism for probably a good 25 or more years. And I've watched these stair steps go up, and my slide keeps getting bigger and bigger. So early this year, the prevalence among 8-year-olds was found to be 1 in 36. So that's pretty high. Back in 1980, it was one child out of every 2,500. So now if there are 36 kids in a room, one is likely to have autism. So also updated are characteristics in terms of the number of boys versus girls. It's almost 4 boys for 1 girl, but that's been going down a little bit. We're starting to identify girls better. And so in terms of girls, it was 1 in 27, and it was even lower than that a few years prior. Now it's 1 in 23. 1 in 88, I'm sorry. For the boys, it's 1 in 23. So we can see many more boys than girls, and that remains pretty consistent. Most children on the autism spectrum do not have intellectual disability. And so the most recent number is almost 38% have intellectual disability, and the rest do not. And when is autism diagnosed? We look a lot at that. The Center for Disease Control wants to have the first evaluation by 36 months of age, by 3 years old. And year after year, we just can't seem to get to that point. And now it's 49 months. 2 years ago, when the previous prevalence study was done, it was 50 months. So it hasn't moved a whole lot. And there's a range. 11 states were involved in this study. And in California, they were diagnosing by 36 months, in Minnesota, 59 months. 2 years ago, it was worse in Minnesota, so we're getting better. But in terms of a country as a whole, we still have a way to go for identifying kids on the spectrum early enough so they can get to early intervention, which we know helps them make the most progress. So I'm going to define it. That hasn't changed a whole lot. Our diagnostic statistical manual has defined it as a disorder that is a developmental disability characterized by persistent impairments in back and forth communication with restricted and repetitive patterns of behaviors and interests. It can persist throughout life. The big word is impair. It has to impair everyday life. So if you have a kid who's trucking along, doing great, even if they have these other things going on and they're functioning fine, they don't have autism. It's got to be something else. So it has to impair everyday life. And so that was the developmental definition. We also have the biological side of things. And so the developmental disorder is highly heritable. And remember that there's some updates on that as well. And non-genetic effects may influence autism. So we've been looking for years for things like, is it caused by water supply or vitamin deficiencies, all sorts of things. But we're finding that when we look at twin studies, that tells us identical twins, right? Both should have autism. In older studies, the definition they used to identify autism was not as broad and well-defined as it is now. The newer studies with a better definition, they're finding almost 100% between identical twins. So they're finding that it seems to be primarily inherited. So 98%, if one identical twin or monozygotic twin has it, the other has it. And in terms of statistics, when they put in that margin of error, they're basically telling us it's essentially 100%. When you look at dizygotic twins or non-identical twins, you'd expect like 50-50 probably. They're getting 53 to 67% are both on the spectrum. So this is sort of groundbreaking. This was a study done in 2016, looking at all the well-done studies on inheritance of autism in the world, from Northern Europe to Japan to us in the USA. And these were the findings. And our American Academy of Pediatrics published this in their update on autism, saying, folks, it looks like it's very much an inherited disorder, which a lot of us in this room are aware of. And so they're finding that unless a suitable, well-designed new study comes forward to disprove this, the claim that there are lots of environmental factors contributing to autism should be put to one side by now and focus on the genetics of autism, which is where we may find answers and ways to make things better. There has been, however, a more recent study done across 5 different countries. It was population-based, meaning there were a whole lot of people involved. And they again found high heritability and environmental contributions were minimal. And so in terms of updating, those are some of the big things that we're seeing now with autism. But let's go through to the diagnostic criteria, which again, many of us in this room know, but we have 2 areas or 2 domains: difficulties with social communication, difficulties with restricted repetitive behaviors. And we need to meet all the criteria for the social communication because that's key to autism. And for restricted repetitive behaviors, we need to meet 2 out of the 4, and that gives you the diagnosis. And this looks very nice and neat, but it takes lots of evaluation, and Molly's smiling because she knows we have a big team that works on evaluating autism. And so those are the diagnostic criteria. There are other disorders that can occur with autism. Autism is very complex. And you can get behavioral disorders, speech and language, epilepsy, up to 20% can have seizures, motor problems using your hands or balance, coordination, the big muscles, problems with sleep. There can be intellectual disability or developmental delays, of course, genetic problems, metabolic, the way your body takes food and breaks it down may not be efficient, and you may have these byproducts that cause toxicity to the body with metabolic problems. Stomach problems, I see a lot of constipation, and sensory integration challenges. And so lots of things that can go along with autism. So what is autism? We're finding it's highly prevalent. It's pretty common. It's highly heritable. It's complex to diagnose, and it's complex to treat. So that's what we've got. So a family is in my evaluation room. We've gone through a full evaluation, and I'm telling them that their child is on the autism spectrum. And Over 30 years, I have seen a range of reactions. There's grief, denial, anger, fear, confusion. One of the big ones I see, which I appreciate Molly's presentation, is guilt. I pick up on that a lot. Know that you're not alone, parents with kids on the spectrum. Many parents experience these feelings. However, as you work through the feelings and find support for that, you still have to do that stuff of finding supports, seeing who's in the community to help, finding services. So it's tough. So there are resources out there. Big three things you want to do: get information, communication, education. So information, you can get that from the schools. There are lots of supports out there. Autism Society of America, Autism Speaks are good ones. Autism Speaks I'm mentioning because they have very good parent guides. And the first 100-day kit is very good to kind of give you direction for the first 3 months, what to do. In terms of communication, it's how do I tell the grandparents? How do I tell my sister? Support groups are great. You get communication from other parents, friends. There are resources like the grandparents guide or a siblings guide to help guide you through how to break the news and how to also communicate what you need. And so you're looking for support from people. And so that's important as well. So treatment. We're working with grief, we're working with guilt, we're working with loss, anger, and we have to address these things. The American Academy of Pediatrics has 3-4 areas that they want addressed for the treatment of autism. One are those 4 symptoms I talked about, the social communication stuff, and also those repetitive behaviors like flapping or repetitive vocalization, ticka, 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 whoop, whoop, whoop. Working on those core things that you see in autism, and then functional independence. That's number 2. How do I make myself a meal in the morning for breakfast? How do I navigate the community so I can get to work? How do I develop friendships? What would I do in a job environment? How do I get dressed in the morning? So functional independence. And then number 3, which is also one of the big 3, behavior problems, which is very key and prevalent, common in autism. So there's a lot of information overload. I like to amuse myself by Googling every couple of months the word autism. And since I started this talk, I would get about 10 million hits. Now it's almost 1 billion hits when you type in the word autism. And that was 2 weeks ago. In less than a second, that came up. So there's a lot of information for us to handle as parents and myself as a developmental behavioral pediatrician. There's a lot out there. And so I'm going to try and go through the main things, the main takeaways that I want you to know. And we'll welcome questions because a lot I won't be able to cover in this time. But we want to know, what does my child need? It's really great to keep organized records. I love when a parent comes in with their ring binder filled with all the evaluations, the IEP, the individualized education program from school. All of those things help me to be able to help their child. And identifying what your child needs, we do evaluations. I'm there on the floor doing an ADOS. We have our team meeting where we put it all together and make a big report, probably longer than you want to see, but the main parts are the beginning and the end. And the end tells you what to do, the assessment and the plan. So that's the meat of it. And the other stuff is for therapists and teachers and all that other information that's needed. Hearing, we want to make sure kids can hear. There are some things in the literature. I remember one, the misdiagnosis of Matthew. He actually was deaf and not on the autism spectrum. So you really want to make sure your child can hear. School services, therapies like physical therapy, occupational therapy. If there's worry about seizures, epilepsy, getting an EEG, early intervention in the home. So there are lots of things. I call this the alphabet soup because there's lots out there in terms of behavioral interventions, and ABA, applied behavior analysis. There's the naturalistic developmental behavioral interventions. ABA, applied behavior analysis, has given rise to a lot of other ABAs that are based on this, that have different names. We have moved happily toward more naturalistic intervention, which I'm a big fan of. So we have the alphabet soup. Where did it come from? There was this guy, B.F. Skinner, and he discovered that if you dangle the carrot, something that a child wants, a person wants, you can shape their behavior in order for them to get the prize, the high five, or the toy, or the gift, or the praise. And he called this operant conditioning. Behavior is controlled by the consequence, the carrot at the end. And it's based on willful actions. You can shape it in a way that the person internally wants to exhibit this behavior in order to reach the goal. So, a researcher named Ivar Lovaas also took these principles and turned it into something he called discrete trial training, and worked with children on the autism spectrum. He started in a residential setting, treating children using this method of helping to shape their behavior. Lovaas used primarily positive reinforcement, but he also used negative reinforcers as well, which myself and many others frowned upon. He did find that with positive reinforcement, he was able to shape behavior, he was able to teach new skills and help children on the spectrum make progress. He created learning units with a beginning and an end and took data to see if he was making progress, and he saw positives. But there were many controversies with this. He used punishments, and it was felt to be too focused on eliminating behaviors. Some of these behaviors are okay. You can just generalize them and adapt them to the child's home and situation and life. Some of the skills taught didn't generalize. The child would only be able to do this in the therapy room, but at McDonald's or at home or at school would not be able to exhibit these behaviors. Too demanding, didn't appreciate neurodiversity. The behavior analysts, the board certified behavior analysts, behavior specialists that grew out of this original theory from way back with B.F. Skinner in the early 1900s, gave rise to more person-centered planning and the naturalistic approaches that we use now. More normalization, mainstreaming, looking at clients' rights and protections, and giving rise to naturalistic developmental behavioral intervention, positive behavior support intervention. And we still have the label applied behavior analysis, but it's very different now from what it started to be in the 1960s when discrete trial training began. And so what we have now is something that is child focused and input from parents. What are your family values? So what is ABA? Applied behavior analysis, and it has many other names, as I was mentioning, is looking at positives. Just a quick, very simple example. My teenagers, when they were teenagers, they're adults now. I hope they're cleaning their rooms now, who knows? But they weren't cleaning their rooms, so you don't get your allowance. So you decide, okay, I'll clean my room most of the time, and then they earn their allowance. Negative reinforcers, you've got parking tickets, you're not paying them. Your car will get towed if you don't pay them. And so pay your tickets, car not towed. And so it's a win-win, more so with the positive reinforcement for everybody. For every negative reinforcer, you need 3 of those for 1 positive. So the positive is very powerful and very effective. ABA, it's evidence-based. We've got decades now of research that has labeled it by the US Surgeon General and the American Psychological Association as best practice treatment. And again, it's that whole alphabet of soup that I was showing you. They go back to those original operant conditioning principles. And it's focused on positive reinforcement. And so ABA therapists come in different varieties. You can have a board certified behavior analyst that has a master's degree, a doctorate, a bachelor's degree, master's degree, doctorate. They can supervise, they're certified. You have persons who are doing ABA, but they're under the supervision of a board certified behavior analyst that's certified. And if they're not certified, they can be guided by the board certified analyst. So behaviors, you can have disruptive behaviors, you can have behaviors that you want to shape to more normalization, or you want to shape the environment to adjust to the behaviors. There are many things that you can do. However, you need to crack the code. What is causing a behavior? What's the ABC of the behavior? The A is the antecedent. What happened before the behavior started? Was this child presented with a math worksheet they didn't want to do? What does the behavior look like? Are they throwing things? Are they falling out on the floor and having a meltdown? Are they running out of the room? And C, what's the consequence? Do they get out of doing the math worksheet? Do they get attention? What is the motivation for the behavior? So that's very important, because if we can't analyze the behavior and figure out what's causing it, we can't come up with a plan. We can't get to the why. We can't get to the solution. So a functional behavior assessment, which many schools talk about and parents request, it's a way of doing those ABCs. And they gather data, but it's not just a form to fill out. It's actually sitting in a classroom, observing the child, seeing what times of the day the behavior occurred, what does it look like? We want to know, where does it occur? What purpose does it serve? What's going on in the environment? Is it at the end of the day and the child is tired or hungry? Did they not get enough sleep? So there are many things in order to get the information you need to address behaviors or to shape behaviors. So there are different types of therapies in terms of the ABA that we use primarily for our younger kids, our toddlers, preschoolers, to help them make those big progressions in getting more socially connected and learning skills. Discrete trial training, that's kind of the old one, where it's very repetitious. Some children need a lot of repetition, one-on-one, lots of guidance by the therapist. Then there's incidental teaching. It's natural environment learning. And the child's in their natural environment. They're at school, they're at home. Excuse me. And you're taking the child's lead. And for instance, you're in the playground and the child Tommy wants to climb up the ladder to get to the sliding board, his favorite thing to do in the playground. So you're trying to teach the word help. And so you might say help, and then Tommy might pause. He may not say anything the first few times. Then maybe he'll try and say the word. And if he says anything, that's wonderful, and you help him. And eventually you might shape the behavior so he's saying that word. In the naturalistic setting, where getting that response helps Tommy to get to the goal that he wants, which is fun, going down the sliding board, that's much more effective, and you can also generalize it to other environments. Verbal behavior, that is targeting language that connects to a word and connecting it with its meaning. Something as simple as brushing your teeth. What is this? The child might name it. It's a toothbrush. What do you do with it? Brush your teeth. So you're taking a word and you're teaching the word, but it's not just rote repeating words. It's attaching meaning to the word in the natural environment. The natural language paradigm, you're in a therapy session in a little room. and you're teaching the child to say book. They say book, they get a goldfish crack. So you've taught them to say the word. What's more powerful is at home, they say the word book and they get their favorite book. That's a much more powerful connection. And again, more generalization. And as I'm kind of pointing out here, the natural environment, taking the child's lead is so powerful. Pivotal response training, that's when you kind of go with whatever the child's interested in that day. So if they're interested in dinosaurs, you might use the dinosaurs to teach counting or to teach sharing or back and forth social communication. So pivotal response training is very fluid. So those are the big ones. Most behavior analysts will use a combination of a little bit of all of those that I mentioned to create what is needed. Because if you meet a child with autism, you meet one child with autism. So it has to be tailored to what the child needs. And so little bits from everything is used. Components of ABA. You have board certified behavior analysts doing direct therapy or supervising. You create an individualized program, and the family values, the child preferences need to be included. So if you're, doing an intake with someone who says they're going to do behavior support and they say, okay, we're going to do this, this, and this, and this, and you haven't been asked what your goals are, that's not a good place to be. You want generalization of skills to be able to do the skills at home or at school, etc. Functional skills to enhance quality of life. It can range from more didactic teacher-led to more child-led to play-based. And data is collected so that from 1 month to the next or from 1 week to the next, we can see if we're making progress. Team meetings are important. If you're not making progress, what are we going to do? So you regroup. Prevention of challenging behaviors. Although a lot of times in my world, families are seeking ABA for their young children to help with that social communication and the restricted repetitive behaviors, the challenging behaviors are also addressed by ABA providers, and sometimes we forget that. But why? And why is it one of the big three that the American Academy of Pediatrics says we should treat? Because it's common. So take a look at that top. When we look at behaviors, we are seeing that behavior problems, conduct problems, almost 61% of kids on the spectrum. But look up here, if we add things like ADHD or anxiety, other mental health things, it's almost 80%. That's huge. Look at this, 5.9%, almost 6%. So autism, not on the autism spectrum. And this population of 5.9% included kids with intellectual disability, with special health care needs, as well as the general population of kids. And we still see that big differential. And so it's something that's unique to autism. And so a lot of emphasis is put on managing behaviors to remove that brick wall that gets in the way of a child moving forward. Self-injury is also high across the lifespan of a person with autism. 40 to 50%, that's a lot, will have exhibited self-injury, headbanging, pica or eating non-food things, scratching self or others, rumination, self-hitting. And so who's at higher risk for self-injury? Kids that have limited language. And in my mind, that might be giving rise to the frustration, cognitive delay, hyperactivity, a high degree of restricted repetitive behaviors, a high degree of social skills challenges. They are at greater risk. And so safety first. I work with families where there's a 16-year-old in the family that has intellectual disability, autism, and maybe aggressive. And so we want to assess for safety of the child, of the family members in an ongoing fashion. There are community services, many of which Molly reviewed in her talk. And You can get a county caseworker, personal care assistant can be available, possibly respite care. Interventions may be needed, parent-child interaction therapy, so parents can get coached on ideas and ways to work on behaviors. And so there are a lot of community services that can be devoted and have been developed to help with that high number of our kids on the spectrum with behavior problems. So when to consider medication? If you have not found a medical cause, if the behavior is associated with irritability, not responsive to behavioral interventions, if there are other mental health disorders, the child may also have ADHD or anxiety or depression. So those are other reasons to talk about medication. But I always like to avoid it whenever possible. There are resources that can also help in terms of things that families can do to help with behaviors. But let's move on to some other therapies. We talked a lot about ABA and behavior support because it's needed at some time or another by almost every family. But so is speech and language therapy. A study looking at 3-year-olds with autism, 87%, almost 90% had speech delay. So it's quite common. And the speech pathologist will evaluate, will find out what the goals of the family are, will look at what the needs are. So does the child need to communicate their wants and needs? Do they need pragmatic language therapy? There's a lot of talk, pragmatic language therapy, pragmatic language. What does it mean? It means coaching a child on how to have that back and forth social communication, orienting the person who's listening to you to what you're talking about. So instead of having a conversation where a child on the spectrum might say, and then it went boom. Well, what happened at the beginning, what happened in the middle, and what is the outcome? So helping kids get through that way of communicating where the listener will be oriented or staying on topic, reading body language, making eye contact, using gestures, all of that is in the world of pragmatic language. It may be individual therapy or group therapy that's needed, or a combination of both. In group therapy, kids get to kind of rehearse what they've learned in individual therapy. In terms of other ways of communicating, picture exchange communication, where a child lets you know what they need by handing you a picture of it, using gestures or sign language, electronic devices. There's a lot out there now with Go Talk and Proloquo to Go, and a lot of those devices. A big thing to remember is that augmentative and alternative communication devices do not prevent a child from talking. It can actually introduce them and help them understand the use of symbolic objects to communicate. And so using words and language as a form of symbols in order to get your point across, or holding up a picture as a more concrete look at it, but it's a symbol as well. And so that can actually enhance the understanding of communication. Some children will imitate the sound they hear on, let's say, Proloquo to Go as the word is said, and start imitating that. So it might actually enhance talking. So what can caretakers do? There are a lot of things caretakers can do. One of my big things is don't turn yourself into a therapist, your mom or dad. And so say ball is not as good as playing ball and using the word while you're playing. Shared book activities, maybe creating a scrapbook of your child's favorite objects with the word written under it, so they can get used to saying the word, seeing how it's spelled, and associating those symbols with each other. Motivators, favorite toys always work to help with sound repetition, word use. And it's kind of a nice thing to, if a child is pointing or indicating something they want, to say the name of the object before you give it. So they want milk. milk, and you can draw it out. Milk, here it is. And you pause a little to see if they'll say the word as you're saying it, but don't force it. Don't turn it into a therapy session. Keep it natural. And so weaving it into your natural daily activities is good. So I'm going to see if this will just play. This is a child who is showing some pragmatic language difficulties. And let's see if we can get this to play.
One thing, can you pause it real quick? So I'm going to mute me.
So there are lots of resources, particularly for young children, for speech and language therapy. And good websites. These websites have milestones, they have activities parents can do. And a lot of the things I was listing, you would find on any one of these websites in terms of what parents can do. Birth to 5, Watch Me Thrive, Bright Beginnings. It Takes 2 to Talk is a nice parent's guide. So let's talk about occupational therapy. Very key for many families. Sensory integration problems are very common among our kids on the spectrum. Fine motor problems, eating problems, disruptive behaviors, and occupational therapists, depending on where their specialties are, can address any one of those things. So how prevalent is it? Among kids with autism, 96% have some sensory problem. I'm always surprised if I have a family where I'm not seeing something. If you add adults and children together on the spectrum, 69 to 93%. However, it's important to remember, there was a national study done finding that between 5 to 16% of people can have sensory integration disorder and not be on the autism spectrum. So that's important to know. And so I love history, you could probably tell. Sensory integration, Dr. Ayers, Jean Ayers, penned sensory integration and created Ayers sensory integration therapy. So she is the mother of the interventions that we use today. However, way back, these gentlemen described autism and first put it under the spotlight. Leo Kanner described classic autism. Hans Asperger, guess what? Described Asperger's syndrome, which we now have classified as mild autism. And so they noted the sensitivities and the sensory problems in kids with autism. But Dr. Ayers took it to the point of identifying it, defining it, its difficulty perceiving and organizing and interpreting sensory information that comes in, the sights, the sounds, the smells, the touches. And she used sensory integration to refer to your ability to either give an appropriate response if a fire truck passes by, or a behavioral response that is challenging and difficult. And so out of that came the sensory integration therapy, which is used today. And we all have sensory preferences. However, if you hear a fire truck, if you walk into Walmart and it's particularly bright, well, Walmart's never really bright, but if the lights or the sounds or the touch bother you, is it impacting your daily function? And there's that word again, impairment. So I don't like loud fire alarms, but I can tolerate it. But if you have a meltdown when that happens, that's different. If you have to wear noise canceling headphones, that's different. So you can have daily chaos with movement, touch, textures in your mouth, smells, things that you hear, visual stimulation. And it can make life very difficult for some of our kids. And so I have some things looking at auditory and tactile, and we'll try and play them at the end. Parents can do a lot in terms of sensory integration challenges, movement challenges. If a child is very busy, fidget toys. If they need that feeling to feel centered, a weighted lap pad or a weighted vest. If someone has visual or auditory stimulation that affects them, we may remove that or lessen it. Or if they seek it, we can have noise machines, white noise or noise makers, rainmakers. We have some on Mayo 16. We do have a crash cart that we have for children that have sensory integration challenges. And this schematic is actually a little bit of what is in our crash carts that we use. We have a questionnaire to find out what kids need. Parents are the ones that know. And so we take parents' leads on what we can use if we have a child that has sensory problems. Physical therapy. Physical therapy is needed for many of our kids on the spectrum. Again, 50 to one study had 100% of children having some sort of motor problem with balance or coordination. That child who's trying to retrieve the ball under the table and bumps their head every time, or just walking down the hall may stumble. It begins early. Lots of gait problems, walking problems, aiming, catching, and poor balance. And so it is common, and gross motor skills are the primary skills, the big muscles, the climbing, the jumping, the running, the skipping that we need in order to be involved in lots of group activities with other children. And what are kids that are 6, 7, 8 years old doing? They're in the playground during recess. They're in gym with their classmates. They're looking at sports activities. And this is likely to be impaired in our kids on the spectrum. So what does that mean? So we're starting down here with this cute little toddler. And remember, it starts early, the difficulty with motor skills. And then we go up to the next level, and the child is struggling even as a toddler with skills that other children are doing. So they're not participating or with their peers, maybe trying sports, having difficulty there. They may get excluded. They're on the sidelines, sitting on the bench. That can contribute to some of the social withdrawal that we see in autism. So it's sort of this vicious cycle where you already have social communication difficulties, and that place where you might be able to get together with other kids and learn skills, your motor skills are getting in the way. So we really need to be proactive about developing programs for our kids on the spectrum that kind of get them going and help with some of those skills. Physical therapy may be one way. There's usually a long wait. Group recreation activities. Actually, at Mayo, we have research going, looking at a group recreation intervention that we're partnering with EA on to see if we can create a program to help in that area. So, complementary and alternative medicines. What is that? Well, by definition, a complementary medicine is a practice that's used in addition to what has been recommended. So those traditional things like ABA and speech therapy and occupational therapy. Some families may want to use something in addition, like maybe vitamins. Alternative medicine is a practice used in place of something that has been recommended. A complementary and alternative medicine is when traditional and complementary practices are used together. Some people call it complementary and integrative medicine. So if you see CAM or CIM, that's in that area of alternative medicines. And so there have been many studies. Most families that have kids that are neurodiverse have tried something, or are thinking of trying, or are using something. Vitamins are very popular. And the main thing is to be safe. Have scientific studies been done to test the treatments? Have they been reviewed and maybe published in a journal where experts in the field have looked over the research? Was it a good study? Was the study based on one child? Or was it hundreds of kids where you can get more accurate information? Will insurance cover it, like practical stuff? And usually not if it's not evidence-based. Will a child have to stop or reduce other therapies they're getting because possibly the cost of the alternative medicines? And what are the side effects? So those are important questions when you're making those decisions. There are some things that we do know. One that we don't know is the long-term effects of high-dose vitamins. We do know too much vitamin B6 can cause neurotoxicity. High-dose magnesium, there has been a death on that for a child that already had motor problems and was on multiple vitamins. Respiratory arrest, muscle weakness, chelation therapy. If you're leaching metals out of the body, you can also leach out ones that you need, like iron. It can lead to things like iron deficiency. There have been cardiac arrhythmias, seizures, kidney problems. Immunoglobulins have been associated with blood clots or allergic reactions. Stem cells is that undifferentiated, I can become any cell of the body cell that you get in the bone marrow. It can become teeth, it can become heart tissue, it can become bone. And so if you're injecting stem cells, there have been cases of growths of tumors in the body, like you have teeth growing under your arm. So that's something for families to be aware of. Hyperbaric oxygen, you can get ruptured eardrums, and the expense. This picture is a family that spent $15,000 to get a chamber at home. They didn't see a change. They sold it on eBay for half price a few months later. So it can become costly. So consider costs with all complementary alternative medicines. Lots of diets, gluten-free, casein-free. If someone is truly sensitive to it or allergic to it, or has celiac disease, something like that, then you certainly want to control taking in these in your diet. However, sometimes it's not. So these in and of themselves are not going to cure the autism. But if there are symptoms from something else, like an allergy or a disorder, they can certainly help having a special diet. I will often work with families on, number one, is this safe? Number two, as I said, with those hits, almost 1 billion pieces of information out there, I don't know everything. So my answer is often, if it looks like it's safe and you want to try it, you can start it at the beginning of the month, write down a list of the things you want to change, make sure everything else is pretty stable, still getting the same amount of speech therapy or occupational therapy, schools haven't changed. At the end of the month, see if you see a change. And I think that's a way to approach it. If you have any questions, go to your primary care provider. And many times it's myself and parents together looking it up, because there can be things that are new or are just kind of outside of the box that I would not have come through. Looking at the information I look at, for instance, there is a website that sells concentrated cilantro for about $20. And they say it's a natural chelating agent. So there's lots of stuff out there. And so you can, together with your primary care provider, go through, does this make sense? And there are some websites that can help. Healthychildren.org, that's the American Academy of Pediatrics, and it's very parent-friendly. Association for Science and Autism, Complete Guide to Treatments. There are many networks that can help you now. One of the things that I always like to say is when you go to a website, at the very end, look for .org or .gov or .edu. Those are usually giving you information that has been researched. There have been studies to back up what they're saying, and it's much more reliable. So these are some of the websites that can be very helpful. And then self-care. And I won't belabor this. Molly spoke about this very eloquently. And it's really nice to be able to take a break. I wonder if this dad is thinking about who's watching his child. Did he get the right respite care worker, or is he really relaxing? Stress is common. And so try as best you can to get even 15 minutes of a break. Ask trusted family members, but work on finding a way to get time for yourself. And it can be very tough. Particularly what I hear from parents is to find someone that they can trust to watch their child so that they feel like they can relax and de-stress. So that's a big one. And I think that parents say it best. So I just wanted to read this. Over my many years, and I'm surprised I was able to do the workout. So anyway, over many years, I have heard a lot from families in terms of guilt. And I have heard and been asked things from, is it because I took a hot bath, to is it because I drank coffee or watched too much television? And that guilt weighs families down. So I just wanted to read this. Autism is not a parenting fail. You've done nothing wrong. You didn't cause this. You haven't failed your child. You were given an instruction manual for a Ford, and your child is a Ferrari. So congratulations. Your child is not fundamentally different from other children. You just need the right instruction manual. Parenting your child will be more intense. You'll need more patience and time. Your child will have intense emotions and needs, but he'll also have intense curiosity, drive, determination, desire, persistence, and individuality. What you'll need to find is the right fuel, the right environment, and the right supports. With those, your child has great potential. With the right supports, he can have a happy and fulfilling life. This is signed Mama Be Good, HuffPost Parents. And so I will end there. And if there are any questions or you just want to talk, that would be wonderful. And thank you so much for your attention.
So do you want to do the videos?
No, we could try them, but are there any questions?
Yes. Thank you for the presentation, very informative.
Oh, thanks.
I just wanted to find out, so typically do you work with younger kids or do you also work with like older kids going to the lessons? So I have a 13-year-old in spectrum.
Mm-hmm.
We just recently moved back to the Rochester area from Canada, and I find like one of my challenges in getting resources for him, because I was notified that needed to have an evaluation, like a US-based doctor, because his autism diagnosis was wrong. So that's kind of been the challenge. And I know we've called Mayo, spoken to pediatrician assistant. It's very wrong with this and
So we see children who are new to us up to age 16. So we can certainly see them. if you have records that are maybe around a year or less old, fairly recent, and sometimes I'll push it, then the wait is shorter because we use those records. Schools typically do very thorough evaluations. It just takes a while for them to get to do it with all the kids. And so we will use that information. We would use information from any therapists that have seen your son, and we make that part of our evaluation. Then we would do, we have different evaluations. They're all team-based. One is enhanced, where we do some testing ourselves to kind of supplement what you have supplied. Or we can have a 2-hour consult with myself or my partner, Dr. Matusik, plus social work, plus RN, and if needed, audiology. So we have sort of a variety of evaluations that we do. The one that takes the longest, that is what we call our multidisciplinary team evaluation, where neuropsychology is involved. And they do 4 hours worth of developmental testing, IQ testing. And to get those slots, it's a long wait. We're talking up to a year, sometimes a week. The others are excellent.
So, like, for example, if I just wanted to get the ball and getting in, or even what, like, fastest, what to go from work, what would I all of a sudden learn? Because I thought maybe I do it through this pediatrician, so like, you know, but I haven't been successful in that for years.
I'm one of the social workers with the smaller program, but how about we can connect, I can get your people, and then I'll follow up with you about kind of next steps and how to, you know, if you're comfortable with that.
Thank you so much, Mom.
What's
Molly and I are on the same
Yeah,
team.
we're on the same team. So
Thank you.
we'll connect and I'll be in touch with you and we'll figure it out. Sometimes it's step-by-step process.
Yeah, that's okay. Thank you so much. Yeah.
Sure.
I'm an OT and I get a lot of teens coming that are newly diagnosed, which is so surprising given that the kind of the average age of diagnosis is young.
Yeah.
So what kinds of factors are leading to that delayed diagnosis? Because some of these kids have even received neuropsych evals when they were younger and like other things were diagnosed, but then older, I guess things became more obvious and then it was. So I don't know what has been your experience with that delay then?
A couple of things. One, it's harder to diagnose in young children. And so a 2-year-old spinning around and laughing, that may be developmentally appropriate. And so I think a lot of primary care pediatricians and providers, family practitioners don't want to overcall. The screening that we use, the MCHAT or the modified checklist for autism and toddlers, the sensitivity and the specificity are not good. So we've done more recent studies on it, and we used it in a huge population. And this was done in Philadelphia with CHOP, Children's Hospital of Philadelphia, and found that instead of being at least 75% sensitive for picking up autism, it was like in the 40s. So the tools that we have are not that great. And we, as yet, don't have an adequate answer as to how to overcome that. We rely a lot on the clinical experience and judgment of our primary care providers. And so our first line people at the door, when these kids come in from the community and a parent is mentioning something, a lot is on their shoulders to, you know, look at what the concern might be and determine. And if you're using the MCHAT, the #1 screener that's used, you have to still use a lot of your clinical judgment. It's not possible.
That makes sense.
And
I usually encourage these families to seek out any resources that are helpful if your child doesn't have that diagnosis, if it helps to look at suggestions for autism So that's great. You like, incorporate that. Was there anything else that I can share with them at a younger age to either help if they do have autism, get them diagnosed earlier? Because I know that goal is 36 months.
Yes. So
Or support them.
our youngest tool in terms of trying to diagnose is called the ADOS, the toddler module for the Autism Diagnostic Observation Schedule. And that starts at 12 months old. I have never diagnosed a child at 12 months old. That's just too young. I have, and it's not frequent, at 18 months old. Using that autism observation module. And so it is possible to look and make the diagnosis in very young children. Some of the things you'll see is the RRBs, the restricted repetitive behaviors. So they may have a toy, but they're just going like this. It's very stereotypical. So they're not, oh, look at this, and not trying to poke it into a hole or poke their finger in a peg hole, or they're not playing with it in a functional way. It's just very repetitive and stereotypical. And then the eye contact. That is also something that you can see in very young children, particularly following someone's gaze. And the pointing. At 12 months of age, children are pointing to get stuff. By 18 to 24 months of age, they're pointing to share their interest in something. And so even pointing is a good indication. That's something else to look at. And there are what we call the red flags. And if a family is given the website for the American Academy of Pediatrics, then they can look at those basic things. Any loss of any developmental skills at any age is also a red flag. So there are some red flags that you can share with parents at a young age. And you can tell them, call an autism center, call Mayo Developmental Behavioral Pediatrics, call the school system. And that's when you start to have eyes watching your child over time. And then they'll get picked up as early as possible.
Okay, thank you.
Sure. And there's more I could say. I could probably talk for an hour, but yeah.
I have another question.
Sure.
I mean, you mentioned in your presentation that autism is very different, and I do believe that because my husband's older brother, we like now that we know about it, like he mentions that he probably was maybe the Esper was for almost like 8 years he was not verbal. Developmentally, but over time, he picked up that he's okay now. And you ever find them there's any relationship, not just the heredity, but let's say in the example of my son, he was born 11 weeks early. Spent almost 11 weeks at developed I think they call it a grade
Interventricular grade 4. Yeah.
And they did mention that he might have some developmental disabilities. So for the first 3 years of our lives, for these first 3 years of his life, he was working with early intervention treatments to be moved. And during those 3 years almost, he was fine and he was meeting all the milestones, even like a bit of verbal capabilities, like he'd say words, kind of imitate and say his sister's name and things like that. And then all of a sudden just regressed. So initially when that happened, we thought, oh, maybe it's just the developmental delay happening because of what we've experienced. Then later on, after being encouraged to see the vision. out, that's when we got like the official diagnosis. So my question, I guess, is, are there ever instances maybe in your experiences where maybe even that, like the autism, but like right now, there's all like classic symptoms of autism, you know, sensory issue.
Yeah.
Yeah, I mean, he's definitely.
It sounds like even with that grade 4 intraventricular hemorrhage, she did quite well initially.
Yeah, he did.
The history of regression is very classic for autism, separate from what he went through in nursery. And so about 1 in 4, 25% of kids on the spectrum, I will get the history from parents. Everything looked fine. There was eye contact. They were starting to say words. And somewhere between, and I've seen a range, 24 months, maybe a little younger, to 3 years, there's suddenly a regression. And they're not looking at me. And they're not saying words anymore. And then comes the evaluation and the diagnosis. So what you described is classic for autism. That being said, if you have a grade 4 intraventricular hemorrhage, that means that the blood didn't stay within the ventricles in the brain. It kind of spread out into the brain matter. And so the chance for some injury is higher, which is why they said that to you. I'm not hearing, the big thing you'll see is something like cerebral palsy, where you have motor problems. And I'm not hearing that. I'm hearing more in line with autism.
I mean, physically, everything is just, it's like when it comes to the communication piece, the skin, and things that maybe you typically would expect somebody to be.
Yeah. So that question. Any other questions, comments? Thank you.
Thank you.